Hello, everyone. I'm going to go ahead and continue with the PowerPoint on respiratory, and we'll be starting on the next slide. We're going to be discussing a few issues that can occur in the upper airway. We're talking about the upper airway, the nasal cavity, the throat, epiglottis, and the first one is infectious rhinitis. And infectious rhinitis is rhinitis being like an inflammation in the upper airway and the sinuses and the nasal cavity. And it's the probably one of the most common infectious diseases, um, sorry, in humans. We just refer to it as a common cold. So rhinitis, infectious rhinitis would be a common cold. Something that's an allergic rhinitis would be cold symptoms, but those occur with some type of allergy. So it's usually caused by the rhinovirus. Okay, so that's a very common cause of the common cold, the rhinovirus. That's kind of helpful to know. Highly contagious, may also see a secondary bacterial infection. So we know that a common cold is a virus. Okay, so antibiotics don't help because antibiotics are for a bacterial infection. But sometimes somebody gets a common cold and they may a few days later get a secondary bacterial infection. It may kind of move into an infection in the sinuses or a strep throat or something like that. Incubation period is about 2 to 3 days. So this one thing about the common cold is that the symptoms do onset slowly. Some manifestations, we've all had it: sneezing, nasal congestion, nasal discharge, sore throat. And sore throat is usually the first sign. And typically it presents about 10 hours after somebody has contact or they get exposed to the rhinovirus from somebody else. Generally, a sore throat is the first sign. And then once they get that, these other symptoms are just going to follow. Non-productive cough, malaise, myalgia, which is like kind of sore muscles, a low-grade fever. So we can get fevers with viruses, but they tend to be much lower than when we get a fever with a bacterial infection. Maybe some hoarseness because of the swelling in the back of the nasal cavities and the back of the pharynx. Headache, chills, those all can people can have all of them or only a few of them. So diagnosis, history, physical examination obviously is going to be helpful. Really, the treatment is just comfort. We just want to treat for comfort. So an antipyretic would maybe be something like Tylenol or Motrin to keep the fever down. An analgesic, again, Tylenol works as an analgesic. It's a minor pain medication to produce comfort. Antihistamines to block histamines to decrease like mucus production. So antihistamines can be helpful. Decongestants, which can be helpful to decongest like the sinuses and the nasal passages because they get so swollen. All those vessels get so swollen up in the nose. Again, antibiotics only if a bacterial infection is present. Humidifiers, any type of anything to kind of liquefy the secretions, keeping the nasal membranes moist. And vitamin C is something that has been shown in literature that could potentially decrease the symptoms and keep them a little bit more mild. And prevention as far as washing hands and not spreading to somebody else. So patients typically don't need to see a healthcare provider when they have a common cold, but if it does present with a high fever, like I said, which can be an indication of bacterial infection, that would be a reason to see a healthcare provider. If they have ear pain, sinus pain, anytime anybody has any shortness of breath or wheezing, regardless of what it's from, that would be a time that somebody should present to a healthcare provider. Next is sinusitis, and sinusitis is an inflammation of the sinus cavities. They can be chronic. Somebody could have chronic sinusitis, or they can have an acute sinusitis that is associated, and acute sinusitis would be associated with a cold. Causes: virus, bacteria, or fungal, virus being the most common. Exudate is pus and mucus, and those types of secretions are called exudates. So the exudates collect in the sinus cavity. So this is a healthy sinus over here, and this is somebody who has sinusitis. So all this exudate collects and blocks the sinus cavities, and it manifests in facial pain. They get a lot of pressure. See how the inflammation up here and the excess mucus, and because of that, they can get some facial pain, nasal congestion. The airways are blocked and they can't breathe through their nose, fever, sore throat. Some other things you can add to it when somebody has sinus infection. This is all connected here. Sometimes they have ear pain. Sometimes they have a headache because they just have all this pressure inside of their head. Maybe some jaw pain. That all kind of makes sense as that pain can radiate. And some halitosis, which is basically bad breath because of the drainage that kind of sits in the sinuses. And then it slowly kind of post-nasally drips down the back of the throat. Diagnosis, history, physical examination, and if somebody has a chronic sinusitis, definitely we want to get some sinus x-rays on them. But if it's associated, with a cold and they have a bacterial infection, they'll be put on an antibiotic. Treatment, decongestants, analgesics, again, antibiotic if it is bacterial. Something else that's helpful for them, there's medication that are like corticosteroids that we can spray inside the nasal cavity. And corticosteroids, remember, decrease inflammation. So like a nasal corticosteroid. Humidification really is super helpful for somebody here. Avoid any type of triggers. And if somebody has chronic sinusitis, they get it over and over and over again. They're getting antibiotics, and a month later they get it again, and they get antibiotics a month later. They really do need to see a specialist, maybe like an ear, nose, and throat specialist or an allergy specialist, because often when somebody has a chronic sinusitis, they may have some polyps inside their nasal cavity, and the polyps can be the provoker, and those polyps could come out, they could be removed, and the person can get a lot of relief from it. The opening gets a little bit smaller so they can have a little bit of tightness in there and difficulty breathing. Diagnosis, history, physical examination, a complete blood count. Certainly for anything, we want to look and see if somebody has an infection. A CBC can be helpful to look at for their white blood cells. Laryngoscopy, where we just put a scope and take a look at the larynx back there and see what's going on down there. And then it says biopsy, rule out cancer. So we don't have to panic every time we get laryngitis, but sometimes somebody has a raspy voice that doesn't go away, or some type of a whispery voice, or a change in their voice. If somebody has a change in their voice that is more permanent and it's not going away, that is something that we want to have them get worked up as well, because sometimes throat cancer can mimic a chronic laryngitis. So they would have to get that biopsy, sent to lab to see if there's any cancer cells in it. Treatment, warm humidity can be very helpful. Resting their voice, increasing fluid intake, because any of these things, when we have a virus in our body, Increasing fluid intake is always recommended because with the virus, we just become very dehydrated. Treating the underlying cause. So what is the cause? What is causing the laryngitis? Obviously, it could be an infection, and we want to we treat with antibiotics for a bacteria, comfort measures for a virus. Sometimes people have acid reflux, and we'll talk about that in the GI chapter. And they get this laryngitis because they have acid that's kind of coming back in the back of their throat, and they're kind of always coughing and clearing their throat. So once their GERD or their gastric reflux is treated, then sometimes their laryngitis would go away. Smoking is another thing. It's an irritant. It can cause some swelling in the laryngitis, in the laryngeal area and in the vocal cords. And sometimes smokers start getting like that raspy voice because of the inflammation back there. And again, those are just things that can cause it. So whatever's causing it is how we're going to go ahead and treat it. So your book may talk about a few more inflammations, but they're mostly related to children. So I kind of just moved on to the lower airway here. And so now we're going to talk about lower airway. You can probably draw and it produces mucus, and this person gets a cough. They start having a cough. Again, causes viruses. 95% of acute bronchitis is due to viruses. Acute bronchitis most generally does not warrant an antibiotic. Very few of them are caused by bacteria, and it's probably one of the most overtreated issues out there, overtreated it's not really a disease. And people feel like they want to have antibiotics for it, but it truly is mostly caused by viruses. An irritant inhalation can cause it. Somebody may be breathing in some smoke or some type of pollutant, an allergic reaction. Vaping is another cause of an acute bronchitis. It causes inflammation in the bronchitis in the whole bronchial area. When we talk about the tracheobronchial tree or the large bronchi right here. Manifestations: cough, dyspnea is shortness of breath, wheezing. They could have any of these or some of these. Low-grade fever, we know that comes with a virus. Pharyngitis, an inflammation of the pharynx. General malaise, maybe some chest discomfort because of the irritation that's going on in the bronchioles. Diagnosis, history, physical examination, and we could see bronchitis on a chest x-ray. So that's something that can be helpful. And typically an acute bronchitis only lasts about 1 or 2 weeks. But the cough, this cough right here, when somebody has a viral infection and they get bronchitis, the viral infection may be gone, but the airway gets a little bit aggravated and irritated. And sometimes somebody can have a cough that lasts 6 to 8 weeks after they get some bronchitis, and they often, go to their healthcare provider like, I've had this cough for a really long time, and the airways just start getting, or they take a while for them to heal. So you can kind of see here's the normal bronchial tree. And when somebody has an inflamed, see how this closes down and it becomes very swollen in here. And then the mucus is thick and it kind of gets stuck in there. And so hence they can have some wheezing and some shortness of breath and feel like they're winded when they do any type of activity. Same treatments that we talked about as far as any other type of a viral issue, antipyretics, analgesics, antihistamines, decongestants, cough suppressants, a bronchodilator, so we can take inhalers that would relax all the smooth muscle and then open up their airways, and then hence they can take in a deep breath. Increasing fluid intake is always very helpful for any virus. Avoid smoke or anything that is causing aggravation. Humidifying air, comfort measures, self-limiting, and once again, if it turns into a bacterial infection, they will put them on antibiotics. Okay, the next thing is influenza, or as the flu. So the flu is a viral infection that may affect the upper and lower respiratory tract. It's a highly adaptive virus, meaning that it just constantly mutates. So some of these viruses, like a rhinovirus, it just continually mutates. So we can't even get a vaccination against it because it changes so frequently. You can't find a cure for it because it changes so frequently. So the influenza virus is the same. That's why you get flu shots for influenza every year, because then they mutate and they're different every year. So there's three different types. So type A is the most severe and the most common. So you should know that influenza A turns into affects humans. So basically, with this, that's why this little piggy and this little bird is in the bed with him. So these are just some H1N1, some different type of flu viruses that are a little less common. But so type A, and this little piggy and chicken, type B, type C. So they have to have a host, like a virus has to have something that it lives on. So it has to go inside the body and attach itself to cells inside the body. And that's why it's so hard to treat a virus, because it's always attached inside to a host. And a lot of the treatments that could some good guesses. About 20% of the population in general will get influenza. And with that being said, about 200,000 hospitalizations due to influenza occur in the United States every year. So there are a lot of especially older people who can get influenza, and that can be very serious for them. It could lead to a hospitalization and it could lead to a death. And don't think that influenza is something that's just very minor. It's caused multiple deaths in the past. Obviously, somebody younger and healthy is just going to be able to fight it. But as somebody gets older, this could be something that could really bring them down, especially somebody who has COPD and they already have compromised lungs. And influenza can be something that could certainly and often does put them in the hospital. Incubation period of 1 to 4 days. So typically, they're contagious one day before symptoms appear, and then being contagious after it incubates. So like maybe on day 3, they're contagious 4 or 5, like about another almost a week later, they can be contagious. So when somebody actually has flu symptoms, they are still contagious anywhere from 4 to 7 days after that. Can cause significant problems with children, elderly, and those who are immune compromised. Manifestations: fever, headache, chills, dry cough, body aches, nasal congestion, sore throat, sweating, and general malaise. Remember, influenza is a respiratory problem. So we use the term stomach flu kind of just a little flippantly, but when we get the stomach quote unquote flu, it is not influenza. It's actually gastroenteritis, and it is not influenza A or B that causes us to get gastroenteritis, that we sometimes lay people will call it a stomach flu. So remember, this is a respiratory problem, not a GI problem. So diagnosis and history, physical exam, a rapid flu screen, which is a nasal culture that we can do in the ER, that tests for virus that they do often in an older population and a younger population. Treatments, antivirals, increasing fluids, rest, antipyretics, analgesic. Again, you're starting to see like this the common things that we can do to kind of help somebody with a virus get comfortable. Prevention of transmission. Hand washing sounds so basic, but it is the #1 prevention of transmission right there. Avoiding crowds and getting a vaccination. Sometimes people have to limit their travel during flu season. They're very prone to this, so they really just stay home during this whole flu season, so they don't, they're less exposed. So this kind of just says exactly what I just said here. Ask your healthcare provider about a prescription antiviral. There are antiviral medications. The thing with the antivirals, they only work if somebody takes it typically before they get symptoms or the actual beginning of the symptoms, or they don't work. So this is something you'll talk a little bit more about in pharmacology. So the vaccination, so that's the flu vaccine. The more people that get vaccinated for the flu, the less it's going to spread. Their antibodies, once you get the vaccination, the antibodies develop about 2 weeks after your injection. It's not a live virus unless you get the nasal spray vaccination. That is a live virus, but this is not a live virus. This is a fake, kind of a synthetic virus that's made with eggs. The influenza or the flu shot is recommended for everyone greater than 6 months old. So let's write down who should not get the flu shot. Obviously, anybody less than 6 months old should not get the flu shot because it is made in an eggshell. People who don't have egg allergies often do not get it, although they generally don't have any problems, but that would make somebody exempt from getting the flu shot. Or if somebody just had the vaccine and they had an allergic reaction or a poor response to it, that would be somebody who should not get the vaccine. If somebody has like a current infection, like they have a cold or something going on, we don't recommend any vaccinations when somebody's immune system is already hyperactive. It's already working on something. So we would ask that person to wait until that current infection is gone. Okay, the last thing we'll talk about is pneumonia. And pneumonia is an inflammatory process caused by numerous infectious agents. It's pretty much an infection or an inflammation of the alveoli. So there just gets to be an infection down in the bottom of the lungs in the alveoli. Causes, infectious agents, bacteria, viruses, injurious agents or events, vaping, gastric reflux, getting in stomach content, getting into the lungs, pulmonary secretion stasis, meaning that somebody can't cough or they can't they can't get their secretions out of their lungs and they sit in their lungs. And they are going to be very prone to pneumonia if we can't move those secretions out of their lungs. So when we talk about infectious agents, there's the virus, which can cause pneumonia, some kind of a viral pneumonia, most commonly caused by influenza and COVID-19 now. Generally, a viral pneumonia is mild. I know we've had a lot of issues with COVID-19. bacterial pneumonia. Kind of the same concept as far as it starts out as a virus, the secretions increase, they stick around too long, and bugs like to grow into anything moist in a dark area, so they often can get a secondary bacterial infection with that. A bacteria is more common than viral, and the most often when somebody gets a pneumonia, it's caused by a Streptococcus pneumoniae. So that's important to know. That causes about 75% of pneumonias that are acquired in the community. And we're going to talk about the pneumonia vaccine, and the pneumonia vaccine, or the pneumovax, is a vaccination against this bacteria right here, because this is what causes the majority of the community-acquired pneumonia. So the fungal pneumonia is the least common. And remember, anytime somebody has a fungal infection, we need to think of an opportunistic infection. It tends to be an opportunistic infection because the person is immunosuppressed somehow. So pneumonias cause a lot of patients being admitted to the hospital, and there's more than 1 million hospitalizations annually, about 50,000 deaths annually, and most commonly we see this in patients who are 65 and older. So some little classifications of pneumonia in regard to where the pneumonia is, the locations. So it could be a bronchopneumonia, a lobular pneumonia, or an interstitial pneumonia, we call an atypical pneumonia. So the bronchopneumonia right here is the most frequent type. It's a patchy pneumonia throughout several lobes, okay? So it's in the bronchioles, and you can see how some of the little areas, a little bit here, a little bit here, a little bit up here. So bronchopneumonia, and it can be through several lobes, maybe the upper right, and the middle, the upper and the middle. Okay, the next one is a lobular pneumonia. Typically, it's confined to a single lobe. So every single thing in this area here is infected, not just kind of sporadic throughout, like these little spots right here. It's more located, a lobular pneumonia. An interstitial pneumonia, which is caused by atypical bacteria, typically Mycoplasma, Legionella, occurs in the areas between the alveoli. Okay, so right around here in the interstitium, around here, routinely caused by a virus or by atypical bacteria. And you're the population that tends to get this atypical pneumonia. You may have heard it called as a walking pneumonia. And it's just in the interstitial areas. Symptoms tend to be mild, and they refer to it as a walking pneumonia because typically you can get treated, get an antibiotic, and just go home, and you're generally fine. It's not usually something that will hospitalize somebody. Another group of categories which are important to keep in mind, because when we talk about pneumonias, when somebody's in the hospital, one of the things you're going to want to know, what kind of pneumonia did they have? Did they have a hospital-acquired pneumonia, or do they have a community-acquired pneumonia? So some important things here. So the first one is an aspiration pneumonia, which we've talked about. And you can kind of see right here, food comes in here. And instead of the food going to the stomach, because that's what it's supposed to do. See, well, this is actually the normal picture here, sorry. So air comes in, food comes in, air goes through the trachea, down into the lungs, and the food goes into the esophagus, down into the stomach, okay? But sometimes somebody takes food and it takes a turn. You can kind of see this person has like a little constriction right here in their esophagus. Sometimes if that epiglottis doesn't close tightly, the food enters the trachea by mistake. And the reasons that people can have aspiration of food content or stomach content, because sometimes it comes up and it goes back down. The stomach acid can come up, and then it goes down into the trachea. Impaired gag reflex, so they don't have the ability to cough. Improper lower esophageal sphincter closure. Think about somebody who's the bottom of their esophagus here. We have that sphincter, and the cardiac sphincter. And if the cardiac sphincter is loose, acid can continually come up, or when they're laying down, stomach content can come up. Sometimes somebody who becomes inebriated to the point of they vomit and they're laying down, and the vomitus comes up, and it's a little bit of it slips into their lungs right here. And it certainly is going to cause a lot of problems, because vomit and acid and food should not be in the trachea. Inappropriate tube feeding placement. Obviously, when we give patients tube feeding, sometimes that same concept